My topic is Global Knee Registry Data Trends. So what is a registry? So it's a system to collect information of arthroplasty outcomes at national level. So it provides an evidence base for safe and effective treatment options. So it's sort of predicting a horoscope. That's what registries help us do. So why do we need them is basically to predict how much is the revision rate, what is the mortality after TKR, what is the brand-wise performance and reasons for revisions. So it adds useful information, aids in decision making for all interested parties. Important instrument for physicians, researchers, patients, health economists when selecting patient treatments. So there are almost 40 to 50 registries available globally. So these are the top ones performing or as enlisted as per the compliance. So England and Wales are the pattern most of our Indians can relate to because the availability of implants and the surgical techniques are quite similar. NJR, then followed by Australia, Sweden, and our own Indian joint registry by ISHKS. So the years are enlisted from where they have started. The Swedish is the oldest in this since 1975. Compliance rates are almost highest in England and Australia as claimed in their registries. Global scenario, so most of them would focus on the median age of person receiving TKR, revision rates, reasons for revisions, and the implant companies, UKRs. Nowadays, the additional thing in the last 5 years is about robotics and computer navigation. So I'll start with Australian registry, and I've covered 3 to 4 registries, and more or less the data is similar. So Australian registry, the most common in the TKRs primarily are common in females, 56.2%, and mean age of the patient is 68.5 years. So gender wise, so the pattern, the blue one line is the females. So it has seen a downward trend in the last 3 to 4 years, whereas upward trends in the males. The primary total knee replacement by age, so the yellow line is 65 to 74 years age group. So this is the highest, followed by the blue line which is 55 to 64 years age group. Lowest here is above 85, which has been steady throughout. This is replacements by patella usage. So the blue line is where no patella is used. So this is showing a downward trend and with increase in the patella use over the last 1 decade. This is about highly cross-linked polyethylene. The blue line is the highly cross-linked polyethylene and the green line is non-highly cross-linked polyethylene. So there is an obvious trend of increase in cross-linked polyethylene since last 15 years. This is proportion of knee replacements. So the blue line is the total knee replacement, yellow is the revision, and the green one is the partial knee replacement. So there is an increasing trend in the partial knee replacement in again last 4 to 5. This is primary replacement by fixation. The green line is cemented knee replacements. So they are showing a downward trend, whereas increasing trend in the cementless total knee replacement. Technology assistance. So the red line is non-technology assistance. This has shown a significantly downward trend. The blue line is computer navigation, which had shown an upward trend and going down. The green line is the robotically assisted, which has significantly increased, and there is a good exponential growth in the 5 to 6 years period. So this is primary UKR with robotic assistance. The green line is showing an increasing trend and then plateauing, and the blue line is non-robotically assisted, a downward trend and plateauing. Robotic assistance is associated with a reduced revision risk. Use is restricted to specific processes, and mobile bearings increase revision rate. In Australian registry, higher revision rates are seen in younger patients and males. Increased risk of revision for infections associated with increased ASA scores and BMIs. So these are 2 slides comparing the cumulative incidence of revision diagnosis of primary TKR with robotically assisted is on your left and without robot is on your right. So the infection rate is more or less the same. What is noticeable is in the non-robotically assisted, the loosening and instability rates are higher, which are lower on the robotically assisted. In UKR, a younger age and female gender are associated with higher rates of revisions, and there is no difference between a medial and a lateral UKR. Revisions from primary UKR undertaken for OA is 13% at 10 years and 30.7% at 20 years. Reasons for revision in descending order: progression of arthritis disease, loosening and pain. So this chart basically shows this is the progress of disease on the purple line. The green line is showing the loosening, and the lowest line is showing the pain. Now, talking about NJR, the National Joint Registry by England and Wales. So 1.3 million primary TKRs registered. Maximum follow-up they have is of 17.75 years. 96.6% are performed for OA. Of these, 90% are TKR, 9% UKR, and 1% are mainly patellofemoral replacements. The median age was 70. Females form 56.3%. Indications are OA 96.6%. They're doing cemented in 83.7%, and CR is the common trend in NJR, 57.6%. So this is a slide showing fixation by year of procedure in primary knee replacement. These are the cemented replacements. The second line is the unicondylers, and the uncemented are showing a downward trends in NJR. This is the estimates of cumulative revision in primary total knee replacements by gender and age. So the age group of less than 55 and males are showing the maximum revision rates, followed by 55 to 59-year-old, and that is more common in males again. The revision indication in descending orders, commonest is aseptic loosening or lysis, followed by infection, progressive arthritis, pain, and instability. Most likely reason for revision in first year was infection. After 7 years or more, less likely than other reasons. Revision is higher in younger patients, men more likely to have first revision, lowest in cemented, unconstrained, fixed bearing. So between 1 and 3 years after surgery, aseptic loosening and lysis with pain were the commonest reasons for revision. Incidence for pain dropping off later, but rising again for aseptic loosening and lysis. Revision, 86% is a single stage. This includes the DIR, that is debridement and implant retention. Talking about unicompartmental, unicondylar is of them 61.5% of mobile bearing. Median age was 64, which is 6 years younger than the average TKR age. Volume increased since 2014, and UKR revisions higher than TKR. The NJR UKR cemented revisions were because of progressive arthritis, aseptic loosening, and pain, whereas in uncemented, dislocation is also seen as the third reason. And cemented UKR at 10 years, 2 times higher in males, and younger patients and males are likely to undergo revision. Risk of infection is lower than TKR, but risk of arthritis, lysis, and pain is higher than TKR. I am talking about Indian registry in a couple of slides. So this is region-wise data. Maximum TKRs are done in Gujarat, followed by Maharashtra and Telangana. Indian registry, the operations funding 38% was by the insurance companies, 30% self, and 22% are others. Year-wise, there has been a significant increase in the number of TKRs. 76% form the PS group and 20.6% are the CR group. The percentage of patella replaced had shown a downward trend and now slightly increasing since 18. Now this is top 10 TKR implant manufacturer. So debut forms 35.6% of the share, followed by Merrill Life Sciences, Max Medical, and Zimmer, and 7% by Smith & Nephew. Reasons for revision in India: infection was the first cause, followed by aseptic loosening of tibia, followed by aseptic loosening in femur, and then instability. Reported revisions, the trend increased till 2016, has been reducing since 16. A couple of slides on Swedish registry. They talk of adverse event in 90 days, more common in men. Surgical events 3%, mainly include aspirations, wound problems, muga, and hematoma. Overall risk is 4.8% of experiencing at least one adverse event. And adverse events, true revisions, 1/5 of the total adverse events would need true revisions. Cardiovascular events are 0.7% and deaths seen in 0.13%. Fixation methods, they have been showing a trend in the non-cemented, increase in the non-cemented recently. Top 3 performing in Swedish registry are next-gen MBT, followed by PFC and triathlon. Whereas in revisions, triathlon was the commonest use, followed by PFC and next-gen. And month-wise distribution, this is interesting. They see a dip in the July month, and maximum knees were done in the October month. Impact of pandemic, substantial deficit in the provision of joint replacement in 2020 compared to 19, 48.8% fewer procedures and 52% fewer knee replacements. There are some fallacies with the registries. Most of them are business driven. This does not show the intricacies of the surgeon, the practices and the methods. So the take home message is registry is an important tool in office counseling. So whenever you're talking to the patients or the relatives or within colleagues to make a decision, especially for the younger lot starting with the practice, how to decide on the implant, what to tell to the patient about the long-term survival and the complications. The trends help in making better decisions every year, and Indian pattern is best reflected in England and Wales registry, though Indian compliance is very low, it's even less than 5% as of now. Thank you.